to chronic obstructive disorders of chronic bronchitis and emphysema. So largely the biggest risk factor is cigarette smoking. So primary cause for both emphysema and chronic bronchitis. Then of course you have air pollution if somebody's working around noxious chemicals for long periods, like in a chemical plant, a refinery. But you just think people in the, it's only in the past, say 20 years, people have stopped smoking. People used to smoke cigarettes a lot more than they did. And then the genetic cause is alpha antitrypsin deficiency. Alpha antitrypsin deficiency. So that's suspected if somebody younger without a smoking history gets emphysema or chronic bronchitis. So if you're young, then they're gonna do and it's a blood test for alpha-1 antitrypsin deficiency. It's not very common, but that's what you think of when the person's younger and hasn't been smoking for a long time. So here we go. 2 chronic airflow obstructive disorders, chronic bronchitis, emphysema, and I just always have to be a pain to throw it in there. It is refractory asthma too. So with with really all disorders though, it's gonna be narrow airway, increased resistance to airflow, meaning air trying to get in, difficulty expiration, and VQ mismatch. I know I heard Mrs. also talking about that. V ventilation, P perfusion quotient. So we have impaired gas exchange. So, chronic bronchitis. So mucus produced in the lower airway tract. Rapid cough longer than 3 months in 2 consecutive years. So, inhalation of irritants leads to chronic inflammatory process. Common irritant, tobacco. And I don't know whether if anywhere in ATI or your book it says, but in medical charts, or I hate to say, but the medical way to quantify tobacco history is the number of packs they smoke times the years they smoke. So that's the pack years. So number of packs you smoke times the years you smoke for. If you smoke 2 packs a day since you were for 40 years, it's 80 pack years. Or you see that term in a documented, that's what that means. And simple connection, the higher your pack years, the more problems you're gonna have. So, I won't read all those to you, but basically, you're gonna get thicker mucus produced because of these goblet cells. The squamous cells impair your ability to clear the mucus, so narrowed airways. So results gonna be what? And if myceliary function is impaired, you think I have all that mucus sitting there and I can't cough it out. So it sits there, what happens? I get infection, get horrible, loose sounding cough. And then with this VQ imbalance, so hypoxia means what? PaO2 below 80. Hypercapnia is PCO2 above 45. And pulmonary hypertension. So pulmonary hypertension means my pulmonary vasculature, my pulmonary arterial venous system has higher pressure because of, it can't get through, perfuse a normal way because of all this thick mucus blocking it. And that can eventually lead to right-sided heart failure. So poor pulmonale is an old-fashioned term that really you don't see too much anymore, except for, where, ATI. So right-sided heart failure is going to be things like, it's my right side that's failing, again, tenderness to my right upper quadrant, peripheral edema, cough. Shortness of breath. Now, so emphysema, so our big things, you can see all, read the fine print, but really, the alveoli become less elastic, and there's less, they get more porous, and I can't participate in gas exchange the same way. They're so big and rigid now. I'm not reading all that, but Reader's Digest version. Have big, not big, rigid alveoli instead of being nice and soft and fluffy and pink. So if I lose those alveoli, I'm losing air spaces, and air gets trapped in the bigger spaces. See, here's how I visualize it. You think of a healthy, and I'm, a big eater. You think of a healthy lung looking like a Three Musketeers. When you bite up Three Musketeers, it's nice and bubbly, it's nice and fluffy, little tiny holes, compared to emphysema's like a crackle, like a crunch. Like big Rice Krispie, that's what an emphysemic lung looks like. Pictures of the same on page 482. Chronic bronchitis, the alveoli are big, but they have a lot of mucus in them. Emphysema, now I have air trapping in the alveoli, so I can't expel the air. And again, the air can't participate in gas exchange, so I'm going to be retaining CO2. So chronically retain CO2 with emphysema. Do a little bit with chronic bronchitis, but typically more with emphysema. And like I said, genetic cause is the deficiency of alpha-1 antitrypsin. So that's when they're young and don't have a smoking history. So with both disorders, I'm going to have increased work of breathing, air trapping, and impaired gas exchange. And then so convenient, on page 483 of your text, it compares emphysema, bronchitis, and asthma. I'll say it again, page 483, table 26.1, compares COPD, meaning emphysema, bronchitis, to asthma. And it's things like we said already. With chronic bronchitis and emphysema, it's going to be smoking, environmental exposure is a big thing. With asthma, more of an allergic component and allergy history. Now, a classic way to explain this, even though it is kind of true. So people with emphysema, so they're known as pink puffers. Pink puffers, yes. They don't particularly too pink for me, but I guess they do have a little bit of a ruddier complexion. So they always come up with notice. I don't want to give too much weight. And then chronic bronchitis, so they're known as blue bloaters.
What the?
Now that one is more true. If you see some of the chronic bronchitis, they do, like when I think, when I see those two words say chronic bronchitis, I think of this poor little old lady. I probably, honestly, thinking back now, she's probably my age, but she looked like a little monster. I hate to say it like that, but she was just like little, like squat woman, always in a horrible mood, of course, horrible, loose down a cough, and they're like big bug eyes out. Bloaters.
Okay.
So early on, mild symptoms, they're both gonna have this, cough, but it's really kind of loose and nasty sounding. Difficulty breathing, exercise intolerance, so that means what? They just can walk really short distances before they get short of breath. They just can, a couple steps and they have to sit down and take a rest. And the cough's more frequent early morning. So typical, you hate to say, smoker's cough, they wake up there, coughing up half a lung. So, chronic bronchitis, so here's the blue bloater. So copium mouse is thick, tenacious sputum. And I'm gonna pick on this woman I work with currently. She, whenever she's walking, because she just has this rattling cough that just sounds like she's about to go under. She coughs like this all the time. And she had a legit heart attack back in the fall, like had to go to cath lab, whole nine, right? What do I see a couple weeks ago when she's out in the driveway smoking again? And she, God forgive me, but she looks terrible, All the smokes haven't been kind to her skin. Like,
Isn't it weird that they get used to that? Like, she works and like through all that. Somebody else.
so they look a little bluish all the time. That's why they call them blue bloaters. They do look a little blue tinge all the time. And this right side of heart failure. So they have kind of a protuberant abdomen, some tenderness up here, because the right side of my heart isn't pumping because of this pulmonary hypertension. So the right side of my heart can't pump to get to my lungs, so things are gonna start to back up. And adventitia sounds like everything you can imagine. Crackles, bronchi. Slower onset. So emphysema, so here's the pink puffer. They're gonna have difficulty breathing too. And here the classic is, this increased AP chest diameter. So big barrel chest. But big barrel chest, and they have little skinny arms and legs. And they're sitting there, usually over the bedside table, giving it this number. Wanting to somebody take them out for a smoke. No. And they're so thin like that because they're literally using most all of their energy to breathe. So classic test-wise about this barrel chest, and these population, the other population can have it, is that they have that clubbing. So thinking back to the assessment, what's clubbing mean? Let me ask anything yet. Keisha, what's clubbing?
It's like when your nails are kind of formed over there really flat, from lack of oxygen, like kind of curved but really, really flat.
Exactly, right, yeah, their nail beds really, they have greater than 180 for that curvature. And true, like some people, it literally looks like little clubs at the end of their fingers from chronic hypoxia. I've seen people with, bad asthma have that too, but the clubbing and barrel chest, that's screaming emphysema. Pink puffer. So, you know, breathing fast, accessory muscle use, like I said, over the bedside table.
So why red?
Why?
Like the other one had cyanosis, so it makes sense for blue, but why is this one red?
Yeah, I mean, they say they look a little more ruddy classically. I haven't always seen that, because there's people with darker skin who have both things, so I'm just going
Male
with
club.
the classic.
No. Yeah, I have. That
Like I said,
sucks.
it's more the barrel chest and the club nails. Yes. Both can, yeah, both usually employ personal breathing just to, in their daily life to breathe. And we're gonna teach them that too, but they kind of do it on their own. So again, you sit leaning forward, so you know, tripod positioning. Now really, people with asthma do that too. Most anybody, and if you're having trouble breathing, you're like, just to get your breath. So that's just the tripod positioning. Prolonged external phase, because they're really trying to push the air out. But again, they have air trapping, whether it's, you know, that thick mucus with chronic bronchitis, or the air trapping because the alveoli are damaged and emphysema, they're trying to push it out. And then they're gonna have a hyper-resonant tone, again, percussive in here. Because it's just, they're really always filled up with the air, like they're not expelling it appropriately. So, in addition to our usual, you know, we're getting a history of they've been smoking like a chimney for years, and they're thin, and you see them walking, and they're, you know, can hardly walk that far. Getting a chest X-ray to rule out what?
TB.
Yeah, like TB, among other things. To diagnose with either disorder, though, is now another spirometry test, forced vital capacity, and forced expiratory volume in 1 second. So these are done, this is not done at the bedside, these are done in the pulmonary function lab. And then diagnosed with their forced expiratory volume is FEV. And the forced expiratory, well, I'm sorry, it should be really forced expiratory volume and then the forced vital capacity over the FEV1. Let me see. I will change that. Yeah, sorry. FEV1 over FVC. I will update it and put it on Sonus. But
This-
really, I would not, there's not gonna be a question that you see. It's gonna be, test question wise, it's gonna be about the symptoms. But just know there's an official test in spirometry to diagnose them. So I'll change that. So it's a decrease in the FEV, in 1 second, and it's really supposed to be FEV over forced vital capacity. So instead of that second FEV, the denominator should be FVC. And then one more time, the alpha-1 antitrypsin levels is for younger people who are non-tobacco users. Though I do think somewhere in my memory banks, people can get an acquired alpha-1 antitrypsin problem too. So it's probably in the spectrum of diagnosis for other things. So it's genetic, but I think you can acquire it. I don't think I'm making that up. So what other tests we do? Our old pulse ox. So now the COPD patient, what's their pulse ox gonna be like? Yeah, low 90s is kind of what their baseline pulse ox is. They're not gonna be 95 to 100. Now, that being said, if they're 87, 86, that's bad for anybody though. We don't want it that low, but they're not gonna be 95 to 100. We're not trying to make it 95 to 100. So conjected CBC with or without the differential. Remember, the lab usually gonna, you know, if the white blood cell count comes back abnormal, then the lab will automatically do a differential. Chest X-ray, which we talked about. So, any teaching with a chest X-ray, again, now it's just make sure they're naked except for the hospital gown. Make sure they're not pregnant. So sputum cultures, because I want to do what? I do want to, see if there's anything infectious. Unless they tell me what? Weight loss, bloodstream sputum, foreign travel, had somebody visit from a foreign country. Unlikely for it to be TB, but check and see. And now they're blood gas. We'll come up later. But here's people who are going to be chronically hypercapnic. So that means what?
High CO2.
Yeah, their PCO2, the partial pressure of carbon dioxide, is going to be above 45. Now, does it mean they're always in respiratory acidosis? No. Now we're going to get hairy. Probably not hairy for the first test because you have a lot on your plate here. But these are people who are incompensated. They could have partial or full compensation for respiratory acidosis. So your kidneys kick in, so you're not, because remember my body wants to be in a neutral state. So it's going to kick in to normalize my pH. So that's when you have compensated respiratory or partial or full compensation of respiratory acidosis. Remember, so because this is not an acute thing. It's going to be uncompensated with asthma, but partial or full compensation here. But for your little heads, I'm just previewing that. So what to do? Assess amount of disease, reduce risk factors, hopefully stabilize, and identify and manage exacerbations early. So big thing first, of course, is don't leave the smoke so long. See, this is depression for many people. Because people say this is honestly akin to heroin to stop smoking. Like it's that bad. High rate of going back to it. I don't mean to make light of it all. Like it's really, really bad. So, and of course, not just for COPD, for lung cancer, circulation problems. There's a million reasons why to stop, and not just tobacco, because now we have what? Electronic cigarettes and vaping and everything else. Like, shouldn't be doing anything. So before to help prevent the disease, after diagnosis, and let's face it, people aren't going to worry about it. Most people are going to worry about it until something's wrong. Now, what's going to probably be most successful though for somebody to stop? Just like with anything, any behavior modification, we got to do what? Yeah, therapy, maybe a little medication, maybe a little support group. Remember, team, multi-pronged approach. Because you just say, now some people, that's how they have to do it. They just put the cigarettes away and they're going to stop. But a lot of people go back. And like I said, we don't have to do all the evil of smoking. We all know those. So, prevention. We want to do immunization. So what immunization is really important for people with COPD diseases? We want to make sure they get, well, so generic name, more generic?
Pneumonia vaccine.
What's that?
The pneumonia vaccine.
Yeah, so pneumococcal vaccine and influenza. So make sure they get those two. And what else we gonna tell them? What's one of our classic top 10 answers?
Fever.
Yeah, hand hygiene,
Oh.
cough etiquette. Avoiding sick contacts, because this is somebody who's chronically ill. Hand washing, cough etiquette, and avoiding sick contacts, like shouldn't be around, the little grandkids going to daycare. Well, maybe that should be impetus for you to stop smoking. Puff rude. Okay, oxygen. So oxygen, of course, is a drug. It's gonna help by doing what? Prevent exercise tolerance, mental functioning, quality of life. So why would their mental functioning be a little bit depressed?
Because of the high CO2.
Right, because lack of oxygen, but really, the high CO2, the hypercarbia. Virtual high five, Captain. So, and it's gonna decrease, how frequent they're coming to the hospital. And then they can do little things. You can go to the, casino trip, get your little portable oxygen tank. So during exacerbation can be used with non-invasive positive pressure ventilation or mechanical ventilation. So that's a big long thing for, unfortunately, more frequently used to intubate people when they're having a really bad flare of COPD. That's really bad because it's hard to wean them off the ventilator. So now that we have non-invasive ventilation, I swear it's literally like a miracle. We don't want them to get to that, but that's oxygen helps too. But oxygen's, we're giving them higher flow oxygen then, but we're controlling their airways. So we're not worried about that, getting sedated, we're suppressing their respiratory drive because we're controlling their ventilation. So, here we go. Remember, normal physiology. We are all taking a breath because, why?
Or oxygen level.
Well, because our normal their physiology is now that their oxygen is low. We take a breath because our carbon dioxide goes up. That's why we take a breath. Theirs is up all the time. So they're taking a breath because their oxygen goes low. If we give somebody with COPD supplemental oxygen, they won't have the same drive to breathe, and they're going to get more and more sedated and eventually stop breathing. And so supplemental oxygen decreases respiration, increased somnolence, respiratory failure. So respiratory failure means what?
Stop breathing.
Yeah, stop breathing, right. Acidosis that's going to lead to death. So here, funny Regina Wright story. Little baby nurse. I'm getting a report from the ER, which is somebody who later in life became one of my good friends. Tell me about her, I should text her. Anyway, so she's giving a report, and I hear this poor guy coughing away because he had probably a combination of chronic bronchitis and emphysema. And I could hear him even give a report, like cough and cough. And I'm like, oh my gosh, this poor thing. Then he goes all the way down, all the way to the end of the hallway, and I can still hear him coughing. Pretty thin person, but he was African American, so he wasn't pink or blue particularly. But he's coughing away. And his pulse ox was like 92, 93. This backstory of, I worked in a surgical unit where we didn't get a lot of COPD patients. So this guy was coming in as an overflow patient. We had this crazy doctor who's probably still there, but he used to make us, in the morning, put oxygen on everybody, on the post-surgical patients. Even if the pulse ox was fine, we would have to, even the residents would help us come, they would turn up the oxygen so everybody's pulse ox would be high, just so the doctor could see them. Would be fake sometimes. And then have them out of bed. Weird. So this guy's down the hallway coughing. Somehow I just lost my mind. It was nighttime, so I should have been fully awake, but I wasn't. Because me, post 11 a.m. I'm fully awake then. But this was at night. This guy's coughing, and I'm just like, I can't take this even coughing. So I'm like, I'm gonna turn up his oxygen. Because to help him out this cough, right? I turned it up to like 3. It was quiet. And then the doctor, the medical doctor came around, they're like, oh my God, that guy was coughing so bad downstairs. And here's me, I'm all proud of myself. In my head, I'm like, I know. I didn't want to bother you. I turned up his oxygen. And he looks at me, he's like, you turned up his oxygen? I said, yeah. I was like, you can thank me later. He's like, why did you turn up his oxygen? I go, because he was coughing so much, like, and his pulse like was so low, they're like, and he was so nice about it, because, you know, that person has COPD, right? I'm like, yeah. He goes, and you know what happens if you turn up somebody's oxygen? I'm like, oh my God. So he rode him down there, and the poor guy he's like half dead. I'm like, Mr. Whoever, he's like literally. And he goes, listen, you won't be bothering me, call me. I'm like, oh, I got it. He goes, and I'm like, I did, honestly, and I'm not kidding you, in college, I slept through many a lecture, but I didn't remember this one. I really did. I don't know what. I just wanted the coughing to stop. I feel like it's fun. And the rest. So when people say to me, does this really happen? Yes, it does really happen. Like, don't give people too much oxygen, or they really will stop breathing. But he didn't. And lesson learned. And here's another one. Along with the albuterol question, this will be Knuckle Sandwich time. You fell out of those N100, shouldn't be falling out again. Not giving him a lot of oxygen. Okay, so now the bronchodilators. So now this is just review time. So we talked all about these: MDI, metered dose inhaler, dry powder inhaler, nebulizer, orally. So, and then why do we want the short-acting beta-2 agonist first?
Open it up.
Yeah, to open up so the other medication can work. But what's it gonna cause? It's gonna cause bronchodilation, but what's the bad adverse effects? Yeah, tachycardia, could be dysrhythmia, but more so tachycardia, feeling more tremulous. You got somebody anxious already because they're not breathing well. And then longer acting ones in combination therapy. So anticholinergics here, so ipratropium. So remember ipratropium, longer duration of action compared to beta-2 agonist. Common to give ipratropium with albuterol. So I know this is under the COPD section, but real life, and somebody has asthma for adults, we give these together all the time. And then there's newer drugs for COPD. They're not drug templates before Michael Wilson said anything to me. But these are newer drugs. I don't know that you'll see them. Just gotta include them here. I haven't seen them yet. I'm not saying they're not either. So here's our nemesis here, methylxanthine. So remember, this was a theophylline, blah, blah, blah. But disadvantages are, so you can easily get toxic from it. Can't give it if they have a smoke, problems if they have a smoking history, which these people have a smoking history. Can't give it with caffeine. So corticosteroids, yay for them, except for, what's their bad thing? Why are we tapering them down?
So their body doesn't.
Right, your body has to start slowly making its own corticosteroids again. So we need to taper these down. Don't stop abruptly. And really that's an important medication teaching for most medications, but especially for corticosteroids. And what's the indication for giving them? That's not on the slide. To decrease inflammation. But think of all those bad adverse effects, and here's even more descriptive. So somebody with asthma could have these too if they're on oral corticosteroids for a long time. So Cushingoid response. So it's Cushingoid because it looks like Cushing's disease, which Cushing's disease is an overproduction of cortisol. So thinner skin with easy bruising. So moon face, really round face. Cervical dorsal fat to the upper back. So buffalo horn. And really those two things do resolve once a person stops, pretty good, like when they taper them down, but this is a reason why people with asthma, like, they don't wanna be on corticosteroids, you know. Younger person with asthma, they say they have to be on steroids for a couple weeks, they're not taking them, because they don't want, you know, these changes in their appearance, so it's not just COPD. So again, poor wound healing, because of why? Immunosuppression, because it does what? Impedes the inflammatory response. Again, insomnia, like the hypomania, or depression, and then symptoms of diabetes. So hyperglycemia, and we haven't had diabetes yet, but tell you right now too, would be increased urine output and increased thirst. So increased thirst, increased urine output, hyperglycemia. And those two things really come from, because your blood sugar is so high, it pulls sugar, the increased glucose level pulls more water into your vascular system. Because remember, glucose attracts water. Again, going back to pesky old N100. So you can have a combo. If you're not controlled with one drug, you can use two. So then we have Advair Discus, fluticasone, and salmeterol. So fluticasone is being the corticosteroid, salmeterol is the beta-1 agonist.
Would we see that again?
Maybe. One, the more reason I put it on here was that I try and do little tricks whenever you can. That own ending, most time you see that it's a steroid if it's ending in that ONE. And just OL by itself is the beta-2 agonist. So albuterol. That L one, I forget the name of it, but that is an OL. There's one thing, steroid and bronchodilator. And then newer medicines for COPD. I can tell you for certain, won't see these test-wise. I really doubt standardized test-wise either. But just there are newer agents. Then obviously you're only going to be getting the alpha-1 antitrypsin replacement if you have alpha-1 antitrypsin deficiency. So this is only going to be used for people with that disorder. So you don't have to really labor over this one a lot. That's easy peasy. So, big fat warning. This is because the medications coming up are respiratory agents, and I think it just I'm thinking just in the design of the curriculum, the decision was made to put them here in this lecture, but typically, you're not gonna tell people who have chronic bronchitis and emphysema to take over-the-counter agents. It's just not a good idea. They should only be taking things under the direction of their doctor or pulmonary team. Because I'm always reading, if these slides get lost, I don't want people thinking I'm crazy. Like, I don't want anybody thinking I'm promoting this. Like, this should be your doctor telling you this, because things that suppress cough and everything like that, it's not that kind of party, you know.